Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball. We've had the absolute privilege of chatting with some amazing Canadian as well as international guests over the past year. While the topics have been broad in range, whether clinical, social, or political, our aims for the podcast continue to remain the same. We hope to inspire discussion, creativity, scholarly research, and career development in all Canadian surgeons. We hope you enjoy our second season as we continue to highlight some incredible guests, deliver detailed masterclass sessions on a myriad of clinical topics, and introduce some fresh new features such as debate and companion formats. We hope you relish the podcast as much as we do.
On this episode, we were joined by Dr. Nick Zyromski. Dr. Zyromski is a liver and pancreas surgeon at Indiana University. Dr. Zyromski gave us a masterclass on pancreatitis, covering everything from classification to endoscopic management to percutaneous drainage. We have a very special treat for our listeners at the end of this episode, so stay with us.
Can you tell us where you grew up, what that was like, and then maybe walk into your training pathway along the way in medicine and surgery?
I'd be happy to, Chad and Amir. It's a real privilege to be here, and I don't think I'd be going out too far on a limb to say most of your listeners probably don't know me. But in any event, it's nice to contribute to this excellent forum. So I am currently a professor of surgery at the Indiana University School of Medicine. I've been here for the last 16 years. This is really I grew up in Cleveland, Ohio. And nobody in my family was in medicine, but I really enjoyed biology and I enjoyed people. And it seemed like medicine would be a good career fit. And it certainly has been. I went to medical school at the Medical College of Ohio, and which has subsequently changed the name to the University of Toledo Medical School. That was in Toledo, Ohio. And also did my general surgery residency at the same institution. After 2 years of general surgery residency, I got connected with a guy named Mike Sarr, who is a GI surgeon at the Mayo Clinic. Mike worked at the Mayo Clinic for his career in Rochester, Minnesota, and I moved to Rochester, Minnesota, and did 2 years of basic science research under Mike's tutelage. And I will tell you, he was and continues to be one of the finest mentors anybody could ever hope for, and a great friend. And so, hugely influential on my pathway in academic surgery. And somewhere along the line, I got turned on to pancreatic surgery, and I think we may talk about this a little bit later, but I realized that I would need to get a little bit of extra training to call myself a legitimate pancreatic surgeon. And so right at that time, Keith Lillamo and Henry Pitt had come to Indiana and established a HPB surgery fellowship. This was one of the first ones that was accredited by the Fellowship Council. And so I was the first HPB fellow at IU in 2005. And then subsequently, Dr. Lillamo offered me a job, and impossible to say no to that offer, working with this group. And here I am. And now suddenly, a decade and a half down the road, here we are. And then, and of course, we've had a series of tremendous fellows, much better than me, following me, including Dr. Chad Ball.
I've interviewed a lot of HPB surgeons, and they all seem to have this shared love of kind of the complexity of the surgery and the pancreas. What drew you specifically to becoming a pancreatic surgeon?
Well, the technical complexity of the operations, for sure, is a draw to all of us. I also really enjoyed the heterogeneous nature of these disease processes, both benign inflammatory pancreatic disease and malignant pancreatic disease. And the fact that there's a huge amount of thought and decision-making that goes into both treatment planning and a lot of times the intraoperative decision-making with these operations. This is pancreatic surgery, but also obviously, hepatobiliary surgery as well. And I think that really, one of the most attractive things is that there's a lot of room to go. if you think about the diseases of the pancreas, we have one of my first mentors is a guy. I think also the thing that is critical is having mentors and guides. And a man named John Howard was John Howard I met in Toledo when I was a medical student. John was probably in his early 70s at that point. And John is one of the fathers of pancreatic surgery in the world. He was an Army surgeon in the Korean conflict and in charge of the Army Research Unit. And I would really encourage anybody who's listening here to take a look into John Howard. He was so humble, but such a giant in surgery. He contributed significantly to the development of the trauma systems in the United States and across the world. And he tackled pancreatic surgery. And it was really some of John's work in the 60s, 1960s, at a time when people were calling for a moratorium on pancreatic surgery, that the mortality of a Whipple was near 25%. And John presented a paper in the late 60s, 1968, to the American Surgical with 42 patients, I believe, with zero mortality. And that really emboldened pancreatic surgeons to continue along the track. So, my interactions with John obviously were critical. But he pointed out to me that, his words were, we are barely at first base in terms of understanding the pancreatic diseases. And unfortunately, now nearly 20 years later, we're still at first base. So for 300,000 Americans every year who get pancreatitis, there's no therapy beyond support. So I think the chance to really move the field, to really investigate these diseases and understand them better and identify points for intervention is a very attractive part of pancreatic surgery to everybody. So anyway, sorry for the long-winded answer, but you're talking about something I love. So
no, that's perfect, Nick. And your description is dead on. Of course, John Howard, there's no question, is a giant in many things, including pancreas. But you've become really an international thought leader in terms of pancreatitis, and I think our audience is getting a little flavor of that up front. So we wanted to maybe leverage that and get you to talk about pancreatitis and walk really what would be a large general surgery community, primarily trainees and faculty, through some of the current issues and that you've done so much work on. I was wondering if you could start with just a general sense of prognosticating acute pancreatitis. Obviously, Ranson's is the classic example, but how do these scoring systems, whether you're Ranson's, Glasgow, and so on, I think there's 7 or 8 of them, are they clinically useful? How do you use them? How good are we at predicting who's going to get really sick and who's not?
Yeah, that's you're leading off with one of the real open areas in pancreatitis, and I'll preface these thoughts by disclosing the fact that I practice at a university medical center that's a quaternary medical center, and we have a huge necrotizing pancreatitis population. We don't have an ER at our hospital anymore, so I don't see people in the ER who are coming in with abdominal pain. I see people who have been outside for 2 weeks and they're not getting better. Those are the main pancreatitis patients that we take care of predominantly. So having said that, though, once you identify somebody with pancreatitis, I honestly think that clinical judgment is probably as good as Apache, Ranson, Glasgow, the Marshall score, the SOFA index, that you need to be a doctor, you need to be a clinician and pay attention to the patient and be aware of the baseline. An 80-year-old person with marginal kidneys and underlying coronary disease and diabetes is not going to take a joke. And so when you see an 80-year-old person with pancreatitis, regardless of etiology, that patient needs to be in a very monitored a situation that's closely monitored. Put that guy in the ICU, put a Foley catheter in them, make sure that they're making urine. Also be aware of the other end of the spectrum. When you see a 20-year-old person, they could have a pretty severe disease brewing and they can hide it. It's like the trauma patient who's good, until they fall off the cliff. they reach that point in the Starling curve and they, or the point in the bleeding where they just can't keep up. So there are some very, very useful markers. For example, urinary trypsinogen activating peptide has been shown in strong research. Some of the interleukins, interleukin 2 and interleukin 8, particularly the pro-inflammatory cytokines, are very good predictors, but unfortunately those tests are really not available widely in clinical use. So, and each one of those scoring indices has its own limitation. For example, the Apache score, I was just thinking about working on an editorial. The Apache is great, but it's really cumbersome if you try to put that into practice in clinical practice. The Ranson's what they call the grave signs. And by the way, we are 2 degrees of separation from John H.C. Ranson, the very thoughtful surgeon who worked in New York City. Ranson's criteria came from a retrospective chart review of 100 patients with severe pancreatitis, and they are still very accurate. But the obvious problem with Ranson's grave signs is that you need 48 hours to predict who's going to get sick. So I guess what I would say is have a very healthy respect for the disease, especially in the first 48 hours. People who get sick with pancreatitis, who get really sick, typically declare themselves early. So if you have a healthy respect, have a low threshold for close monitoring, make sure the patient's end organs are perfusing. These people, it's been described as a burn in the retroperitoneum that totally soaks up volume, so the mistake that's made consistently is underplaying this and not giving people enough volume. And then you come in the next morning and the guy's in acute renal failure because, people are afraid to put him into pulmonary edema. So I think the summary is that clinical intuition in my mind is really probably as good in this day and age as any of these scoring indices. But this is an outstanding area of research.
The next thing I think is important, that's important to kind of review for our listeners, just given the heterogeneity still with which people kind of talk about pancreatitis, whether it's surgeons or gastroenterologists or radiologists, would be to go over the Atlanta criteria. Can you briefly kind of go over the Atlanta criteria and why that was so important for standardizing the way that we talk about pancreatitis?
I think the most important, so the Atlanta criteria for people who don't work routinely in pancreatitis is based on a consensus conference, and the first consensus conference convened in Atlanta. It was published in 1992, actually, in the Archives of Surgery by a guy named Ed Bradley. And the goal of that meeting was to try to come up with some consistent definitions. The Atlanta group evolved and met again, and it took like 5 or 6 years to do this. It was all done remotely. The current one is published in Gut in 2013, and Peter Banks, who's a gastroenterologist in Boston, is the first author on that group. And there are a number of gastroenterologists and surgeons, and Mike Sarr was a big promoter of that the revision of the Atlanta classification. And again, the goal is to get everybody singing from the same page in terms of what are we talking about? Perhaps the most important thing, and so out of the revised Atlanta criteria, there came 3 classes: mild acute pancreatitis, moderately severe acute pancreatitis, and severe acute pancreatitis. And that's really based on organ failure and the persistence of organ failure. So the moderately severe pancreatitis has people with organ failure that resolve, and severe acute pancreatitis has persistent organ failure. That's the fundamental, basic definitions. And then there are other very important definitions, including the recognition of an earlier and later phase of the disease. And perhaps most importantly is defining what are all these intra-abdominal fluid collections and necrosis that happens in patients with severe acute pancreatitis. So as a baseline, about 80% of people with acute pancreatitis, again, regardless of etiology, will have relatively mild self-limited course of the disease. And then about 10 to 15% will have severe acute pancreatitis with variable necrosis of the pancreatic parenchyma and the peripancreatic soft tissue. And those are the patients, the severe acute pancreatitis, necrotizing pancreatitis patients are the ones that we as surgeons are interested in, as HPB surgeons, because we're called on to treat these patients. And again, I think we're going to talk in a little more detail about how this treatment has evolved. But the definitions are defining the early peripancreatic fluid collections, and then over the course of the next few weeks, as the body consolidates these collections and the tissue that's dead defines itself, then that becomes what's called walled-off necrosis, or WON. And the necrosis, again, like I mentioned, can involve either the pancreas or the peripancreatic soft tissue, or both. In many cases, it's both. So again, the Atlanta classification has been an important document that helps us define consistently what are these phases of pancreatitis and what are some of the collections. I would be remiss not to mention the tremendous work of John Windsor, who's a New Zealander and a brilliant guy. And John and his group have proposed something called the determinant classification that I would encourage everybody to look up as well. Perhaps not as widely used as the Atlanta, but really important because it looks, sort of at functionality and what's happening through the course of the disease.
That's such an eloquent description, Nick, and I'm glad you brought the latter classification up as well. I don't know what your experience over the years is, but certainly within Canada, and my experience was in the US, oftentimes everyone uses the term pseudocyst. Like everything's a pseudocyst in a radiologic report, and maybe that's because they don't have the context of time. That something's not a pseudocyst at a week per se. But I sort of think of that, the lexicon of the Atlanta Symposium, very much like the language of grades of injuries in polytrauma or staging in terms of cancer. And both of those two things have had really good uptake. But for some reason, there still seems to be significant heterogeneity in terms of clinicians understanding and using that relatively common lexicon in our world. Why do you think that is?
I think we just have to keep pounding that message. I agree with you 100%. This is the single most misused term in pancreatitis is pseudocyst. I think that, and we see it here, thankfully not so much at our place, but at a lot of places, even major places, that the radiologist will call any collection a pseudocyst. That's a critical distinction, is what is inside that collection, because if you stick a drain, or from whatever angle, percutaneous or endoscopic, into a big chunk of solid, dead, walled-off necrosis, you've contaminated the necrosis. I mean, the concept of how much necrosis does one of these collections contain has tremendous implications in terms of therapy. So that was one of the main goals of the revised Atlanta classification, to make sure people are using this terminology appropriately. And again, still, we're still trying to get the message out with a lot of these things. So the other point, Chad, is that these collections are dynamic over time. You brought up the point of time. And even in one person, over a week and 2 weeks and 3 weeks and a month and 3 months, the collections will evolve, even solid necrosis. A lot of times the necrosis will liquefy and turn into a collection that has a lot more fluid in it than it did maybe in the beginning. The final point about pseudocyst is anytime you think about a collection around the pancreas, pseudocyst included, the clinician must consider the pancreatic ductal anatomy. Mm-hmm. I think that if there's one take-home point from this whole podcast is if you're seeing somebody with pancreatitis and there's a collection, you gotta know what's going on with the pancreatic duct, because that really, really has a major impact on treatment.
Oh, that's so well said. So, maybe to explore that just a little bit farther and unpack it, as Amir would say, essentially the integrity of the main pancreatic duct will drive you left or drive you right, meaning that if it is intact, the prognosis and the treatment of that patient will be fundamentally different than if it's side branch leaks or something smaller. Would you say that's accurate?
Absolutely. Yeah. We see in all kinds of patients major disruptions in the pancreatic duct. So if the pancreatic parenchyma is involved with necrosis, that's a much more challenging disease process to manage than somebody who has even necrosis of the pancreas, even infected necrosis, but it's all extrapancreatic.
Yeah, precisely. I would argue too that, and I think you would agree probably that, the left disconnected pancreatic remnant are probably our most challenging cases, full stop.
That's a very common, very, very common problem that we see. We actually looked at our whole experience with disconnected pancreatic duct syndrome. Tom Mottman, again, one of our outstanding surgery residents and research resident, just published this paper in the Journal of Surgical Research this year, and looked at 647 necrosis patients, and 46% of them had the disconnected pancreatic duct syndrome. So that's, again, and our experience is biased for sure because of our referral pattern as a tertiary referral or quaternary referral place. But yeah, those are really tough problems.
Yeah, I love that paper. That was so well done. I was hoping maybe we could shift gears a little bit here, still stick with pancreatitis for our listeners, but maybe short snappers or not so short snappers in terms of some broad headings. I was wondering if you could talk about antimicrobial therapy in particular, whether that's, empiric, prophylactic, or of course therapeutic. How do you define that, and how do you look at that? And I will reference, of course, Tom Howard's editorial from many years ago in the Annals, which I still think stands the test of time.
As good as it gets
is
the title, and as good as he was commenting on Patch Dellinger's multi-center trial where they tried prospectively to give people empiric antibiotics or not, and found, like every other trial, that empiric antibiotics did not decrease the mortality or morbidity of the disease. So the practice pattern should be, as a short snapper, as you say, don't give people empiric antibiotics. Treat defined infections for a defined period of time. If you're in a situation where you are concerned about infected necrosis, then I think it's okay to give somebody empiric antibiotics, not prophylactic antibiotics, but with the caveat that you are treating that patient, you're treating them for presumed infected necrosis. But you still have to search. That doesn't stop the search for the infection.
This might be getting a little bit nuanced, but sticking with the concept of infection, there's been a number of papers that have come out, I'd say 5 that I am aware of anyway, over the past 3 to 4 years, that look at essentially the outcome in patients with infected versus non-infected necrosis, both in the intensive care unit and outside of it. And it seemed all that literature, and I think it's supported anecdotally from what high volume centers like yours and ours see, the presence of infection, although as a category, infected necrosis may do worse than uninfected necrosis, but in the individualized patients, lots of them are quote unquote have infected pancreatic necrosis, and their clinical trajectory is really quite easy. And then the opposite of that can be true as well, presumably from an inflammatory driver as opposed to an infectious driver, and the genetic response to that. So I was wondering if you could comment on the realities of infected necrosis, because, certainly as a trainee back when, it was all about, do we stick a needle in and define what's infected and then operate on it. It seemed to be very messy. And I think it comes back now, at least in our practice, to look at the patient and make the call based on that. So what's your sense about infected versus non-infected necrosis?
I think it's really, this is a great topic, and definitely, this is in the weeds for sure, but I love it down in here in the weeds. The The problem with any of these papers, ours included, that try to define infected necrosis is that those numbers are wildly inaccurate. You know, there are people without gas in the necrosis who have infection. I mean, if you look back at Carlos Fernandez del Castillo did a tremendous paper in the Annals, man, I think probably 2007 or 2010 or something. I mean, one of the main points was that when those guys operated and they cultured necrosis, when they operated for sterile necrosis, nearly a third of the patients, if I remember correctly, a substantial number of the patients had unexpected infection.
That's right.
The Dutch group has shown that too, and we've shown that too. And then on the other hand, when you culture people who you know are infected, and then you go to the OR and clean them out, but they've been on antibiotics for 72 hours, a lot of times you don't get an accurate culture, and so they don't grow anything. You know, so do you say that person is not infected because you weren't able to culture it, even though you know that clinically and maybe they have gas in the necrosis? You know, so I think that number one is those numbers are really inaccurate. Number two is I agree wholeheartedly that we need to be clinicians and treat the patient. However, if a patient has infected necrosis, that is a catabolic focus in their body, and they are not going to get better unless that gets treated. There are some people who get better completely simply with antibiotic therapy with infected necrosis. The vast majority of the patients, however, need some sort of intervention to evacuate the necrosis. And again, it is a trap to fall into, to just think somebody looks good and put them on antibiotics and send them home for a month. And then if they're not getting through there, or when you select the resistant organisms or fungus in the retroperitoneum, then their physiology deteriorates to the point, and unfortunately, sometimes we see to the point where they're not salvageable anymore. So infected necrosis is a big problem, in my opinion. And yes, I agree with you, Chad, completely that there's a huge variance, and a lot of it depends on the host. You know, that's the thing. You know, and again, I mean, stop me when you need to, because I could talk about this all day, but we are looking at more accurate objective metrics. Elliot Yee is a medical student here. He's at Colorado now doing his residency. Did a tremendous job. We're looking for a dynamic frailty index, you know, something that replaces that expert clinician's gut feeling. What are we looking for? Look at the PNI, you know, look at the nutritional index with the, you know, something that can be applied dynamically through the course of this 3-month, 4-month, 6-month disease to say, okay, this guy is not getting better. It's time to step it up to the next size drain, to a new drain, time to take him to the OR before we reach that inflection point in the physiology where they're not going to tolerate a major intervention. Does that make sense?
Totally. I think that makes a lot of sense. Speaking of nutrition, I think this is a topic that perhaps is getting more traction, particularly among newer trainees. But you know, there's been a lot of dogma historically about nutrition in pancreatitis. For our listeners, can you just talk about what the evidence is around early nutrition, and how do you sort of approach that for pancreatitis patients?
So I'll tell you, you know, again, I was involved with Karen Horvath, my dear friend from Washington, University of Washington, and a GI group led by a young guy from Hopkins, who we were tasked with prospectively looking or trying to look at systematically all the evidence on nutrition in necrotizing pancreatitis, and it's all over the board. So the take-home messages, and again, trying to do this a little more quickly, nutrition is critical. Early enteral feeding is okay for some. Feed the gut when you can. It's not tolerated by many. And so in our experience, most people require, at least in the early phase, which to me is the first few months of necrotizing pancreatitis, most people require some combination of enteral and supplemental parenteral nutrition to achieve adequate caloric and protein balance, again, in this really massively catabolic state. The other point is that the stomach just doesn't work in a lot of people. the small bowel works in a lot of people, but especially in people with a big retrogastric collection, that's the main inflammatory response, and there's a gastric ileus. So I'm a huge fan of the gastrojejunostomy feeding tube, where you can vent the G part. You can get all the tubes out of the guy's nose. You can vent the G, you can feed the J, and at least you can feed some nutrition into the gut. We published a paper about, PEG J and nasojejunal feeding tube. Alex Roach is another great resident. Alex will be our HPB fellow next year, did that work and found that both of them are well tolerated. But feed the gut when you can, but it doesn't always tolerate nutrition. Now, the next level of thought here is that a lot of patients have mesenteric venous thrombosis in this disease. This is an under-recognized and another wildly unknown swamp, in terms of what to do. But what I'll tell you is that patients with SMV thrombus don't tolerate enteral nutrition, and we have a very low threshold to make sure that they get adequate TPN support, total parenteral nutrition. Again, thinking about what's the consequence to the liver, especially if the hepatic blood flow is compromised, and are there anything, special TPN things like carnitine or things that you can do to potentially minimize steatosis from the TPN?
So glad you brought that up, Nick. You've done some tremendous work, your group there, on thrombosis and in general the coagulation system in pancreatitis patients. And I had the pleasure, as you know, of reviewing one of your upcoming manuscripts in Journal of American College that we'll link to in this podcast. But can you go over the concern about our under prophylaxis of these patients and why that is, and how we should maybe measure it and be more vigilant about it?
Sure. Thanks for the pitch, and thanks. There's a sweet editorial that accompanies that paper, by the way, in the JACS. So you should link to your editorial too, Chad. Again, this is clinical work that's based on a clinical observation that necrotizing pancreatitis patients have a very high incidence of venous thromboembolic problems, and this includes both mesenteric venous thromboses that I was just talking about, and extremity venous thromboses. And so we looked at this retrospectively and found that the incidence was 56%. That's a huge incidence. Alex Roach and Tom Mottman published that paper not so long ago. And then we instituted a prospective screening protocol of 4-extremity ultrasound screening on a weekly basis for necrotizing pancreatitis patients in the active course of the disease. This is really facilitated by our pancreatitis nurse coordinator, Kathy McGreevy. And we can, that's another line of discussion. But Kathy, and I'm mentioning all these people's names because these are the guys who are doing all the hard work. It's a real team effort. In any event, what we found was that, yes, indeed, we validated the finding that of this extremely high extremity DVT rate. And what we found is that by instituting anticoagulation, we prevented symptomatic pulmonary emboli in anybody who didn't have a contraindication for anticoagulation. Now, that was all background getting to your question, Chad, which is the next layer of investigation is trying to figure out what is the mechanism of this hypercoagulability of pancreatitis. And when we have some preliminary data looking at factor 10A and found that we are under prophylaxing people with chemical prophylaxis. And so the next step in this work is looking at developing an algorithm to give people appropriate prophylaxis. There are a few caveats. Number one, I also must acknowledge that I've stolen a lot of these ideas directly from the trauma literature. So to you and all of your trauma pals, thank you, and sorry for stealing your stuff. But it applies also to these diseases. The one thing that we should discuss that's a potential, at least theoretical concern in pancreatitis is the problem of bleeding when we give people very high doses of anticoagulation. And we haven't thankfully experienced major problems with bleeding up to this point, but that definitely needs to be on the table, and especially in the circumstance where somebody may have a visceral arterial pseudoaneurysm brewing too.
This is such a neat line of investigation. Shifting gears a little bit, I'm curious what your thoughts are, and this is a real, I think, practical issue that again sees a lot of controversy and a lot of heterogeneity across different institutions. But where do you see the role of early ERCP in pancreatitis? Is that something we should be doing? Is that are there certain situations where that's helpful? Like, for example, if the bilirubin is also concomitantly high, how do you sort of approach that in your mind?
So the question is, in patients with biliary etiology, which ones will benefit from early ERCP? And the answer, I think, is reasonably as clear as any in this field. There have been several prospective studies, primarily led by the GI groups. And so if somebody is not getting better clinically in 36, 48, 72 hours, in the first 72 hours, somebody who's failing to improve clinically with biliary pancreatitis, and some of the liver chemistry numbers, bilirubin, alkaline phosphatase, are climbing or not falling, those are the patients who should get an early ERCP. Early ERCP should not be done routinely. That's been shown pretty clearly. The caveat is that this is a tough call, because you can have edema of the interpancreatic common duct, especially with head necrosis and developing head involvement. And so it's really helpful to have a dialogue with an expert endoscopist involved with this process. When ERCP is undertaken, it's really important that the endoscopist doesn't inject the pancreatic duct, because they don't want to exacerbate the inflammatory response in the pancreas, and we don't want to introduce bacteria into what is presumably a sterile, in the early days, as a sterile situation. So that's the rub with doing ERCP, is that you open the gateway to the gut, and that's a easy access for the gut flora.
That's well summarized. Nick, I want to transition a little bit now to the concept of drains, percutaneous drains in particular. I know you know our senior partner, Francis Sutherland, well, and I think every time a drain goes into one of our patients here, a little piece of him dies. I'll also maybe just frame it with the caveat that at centers like yours and ours, we're very lucky, because the interventional GI groups and the interventional radiologists and us, we're all so close, and we all treat these patients together in such an important multidisciplinary, multifaceted way. I don't know how you treat these patients in 2020 to best effect without these complex and heterogeneous groups. But, having said that, percutaneous drains do get put into these patients, usually from St. Elsewhere. Tell us what your overall view of putting drains in collections is, with regard to maybe timing and selection and utility.
Well, I think you hit another real take-home message, Chad, which is, in this, treating necrotizing pancreatitis is a team sport. It's really critical to have a captain of the ship, and it doesn't matter who it is. I take ownership for a lot of these patients, but could be a gastroenterologist, could be an internist, could be a pulmonologist. Somebody's got to see these patients through this 6-month course of disease, but there has to be input from the experienced gastroenterologist, experienced interventional radiologist, for optimal treatment in this day and age. I feel Professor Sutherland's pain. 20 years ago when I started doing this stuff, if we saw somebody with a drain in them, that was heresy. Into a pancreatic collection, percutaneous drain. I think percutaneous drainage is one of the most significant advances that we've seen over the past decade. And we learned this from the PANTER study, from the Dutch prospective study, looking at the step-up approach. This was validated in Karen Horvath's study. The percutaneous drainage was introduced back in 1998 by Pat Freeney, who's a radiologist at the University of Washington. And I would highly recommend anybody interested in this work to read Pat Freeney's paper from '98 in American Journal of Radiology. That's seminal work. He identified the fact that people with disconnected duct don't do that well. What we've learned about drainage and how we use it in this day and age, percutaneous drainage is often the first step in the step-up approach. Percutaneous drainage really, though, depends on the anatomy of the necrosis. And again, getting back to how do you treat these patients, it's such a heterogeneous disease that patient selection and the patient individual situation, how are they doing clinically? Is the necrosis infected, et cetera? What's their nutrition? And really important is the anatomy of the necrosis. A localized collection in the lesser sac, even with a disconnected tail, is pretty straightforward to treat. On the other hand, the patient with necrosis that's extending down both paracolic gutters, including the lesser sac, multi-field necrosis that and a duct disruption or SMV thrombus, head involvement, that's a much different story. So, but in any event, if somebody has infected necrosis, especially if they have multiple field necrosis, we'll start with a percutaneous drain. And then within the next few days, we re-image the patient to see what's happening to the collection, look at the patient's clinical progress. If we're making progress, then we'll ride it out for a little while. If we're not making progress, if there's still a big volume of necrosis, we'll either upsize the drain, put another drain in to irrigate one vigorously and have a point of egress. We'll consider an endoscopic approach. The Virginia Mason group in Seattle has championed the dual modality, so-called dual modality, percutaneous and endoscopic. But what we found is that consistently, at least a third of the patients will resolve their necrosis with percutaneous drainage only. And that's, again, that's a huge, huge advance in treating this disease process. I would also like to refer anybody who's listening to the work of Rajesh Gupta and his group at the PGI in Chandigarh, India. Rajesh does tremendous work in pancreatitis, and those guys have published great work in the Annals and other surgical journals about use of TPA, streptokinase, and most recently hydrogen peroxide, these injecting the drain to try to break up and liquefy the solid necrosis. And again, John Windsor's group has done seminal work in this area too. John's looking at trying to isolate the compounds in leech saliva, which one of those maggot saliva, not leech saliva. And the maggots eat dead tissue, but they don't eat live tissue. And so which one of those compounds might be available? We haven't sent them any in a while, but for a while we were sending necrosis over to New Zealand so that those guys could take a look at which one of those compounds would liquefy the necrosis. So
I think you've touched on so many important points there. And, maybe I would take the liberty of summarizing it, which is, at the end of the day, the multidisciplinary nature, again, is so critical, because I think when people read, you and I write a paper on transgastric necrosectomy, the perception from the outside is often like they operate on everything. Or you read a nice percutaneous paper, they put drains in everything. And really, that's not the case. When we sit on panels, we usually all agree on exactly what to do from all these different disciplines more often than not. And so, I think you're right. The group has to be a collective, and it has to be a single unit working together, with lots of different heterogeneity and backgrounds. That's the only way we're going to get these patients better.
Super terrific summary. I think we're inching there incrementally. I really think that, it's a heterogeneous disease. There are multiple approaches. Oftentimes, multiple approaches are useful for the same patient over time. And I think that we really, a lot of times I'm invited, like you say, I'm known for this disease, and I get called to talk at GI meetings. And a lot of times I'm the sacrificial surgeon on a panel of gastroenterologists. And my message is, look, this is a team sport. We got to get away from the mentality that my way is better than your way. GI is superior to surgery. Surgery is superior to GI. Percutaneous trumps everything. It's just not true. Every modality is important for one patient or another. And the trick is figuring out which patient needs what approach and when.
Well, exactly. And the other thing that you touched on that's so very important is the longitudinal care of these patients.
Yeah.
So, banging in a drain and walking away is not going to be helpful. Putting an endoscopic stent in is not going to be helpful if you do it once and you're not willing to take those patients back over and over and over and debride them through, a big axiom stent or something. And the same thing applies to us. It's just that historically, I think in most places, surgery does provide that longer term care as opposed to some of the other types of services, but certainly in pancreatitis centers, that's clearly not the case.
The median time to recovery from necrotizing pancreatitis is almost 6 months for patients who don't die early. This is a long-term problem. And what we're finding out is some of the even longer-term sequelae, which are fascinating, duodenal strictures, bile duct strictures, endocrine and exocrine insufficiency, rare but crazy things like, we're looking right now actively with a GI psychologist at what Marty Freeman termed post-pancreatitis stress disorder. Every single one of these patients is depressed. Mm-hmm. When the surgeons are making this diagnosis, I'll tell you, it ain't subtle. You know what I mean? And but what can we do up front to intervene? We borrowed some of your guys' work about mindfulness interventions. We're going to apply some of that work. I'm a musician and I'm fascinated by the effect of music therapy. We're going to try to do some music therapy, to try to get some of these, address some of these important holistic and long-term problems with this disease.
Well, that's so beautifully said. And, you dance on an indirect topic there, which is really how we communicate this to patients on an individual level. I learned from you guys, but usually up front, I say to these folks with really bad necrotizing pancreatitis that, this is probably going to take a year out of your life. You're going to look back at 2018 and say, wow, that was a crazy year. And if it's shorter than that, I think they're happier. And the worst thing you can probably do is undersell it up front, especially if you're not comfortable with the diagnosis and the long-term management of these folks.
Yeah, I think that's a fair take-home point for everything. Always paint the picture darker than it may be. Then when they get better, they say, "Oh man, Dr. Ball, he must be a great surgeon. I got better in 6 months instead of a year."
Yeah, smoke and mirrors.
Right. Honesty, Chad. Honesty. That's the key.
Speaking of operations, your group and the Calgary group collaborated on a great paper talking about transgastric necrosectomies, and it was interesting. When we were studying for our equivalent of the American board exams, the Royal College exams, talking to other residents across the country, and I'd say probably the majority of institutions really didn't have a lot of people doing necrosectomies this way. I'm certainly biased because I've had the opportunity to watch Dr. Ball and some of the other HPB surgeons in Calgary do this, and I think it's a great operation. Can you describe what this operation is and sort of why your groups really felt that this was a good way of dealing with pancreatic necrosis?
Yeah, thanks for the shout out. I think that Michael Dreiger was the one of your contemporaries probably, or junior residents who was really important, did a lot of the important work here. Obviously, Dr. Ball shepherded this paper through. This was a multi-center study with Calgary IU and Brendan Visser and his team down at Stanford. And so the question is, how do you approach somebody with a transgastric pancreatic debridement? First of all, determining which patient is appropriate for transgastric debridement is important. And so we highlight the fact in the manuscript that this is a really select group of patients with necrotizing pancreatitis, probably 15% at most of everybody with necrosis. And the ideal situation is somebody with necrosis that's confined to the lesser sac, that with or without disconnected tail. If somebody has biliary pancreatitis, surgical transgastric debridement, and transgastric debridement can be approached endoscopically too, of course. There are trade-offs, but if somebody has biliary disease, you can take the gallbladder out and do a cholangiogram at the same time. The way we approach it, we've done a few of these laparoscopically, and we find that it's easy enough to do with a short upper midline incision. We use ultrasound religiously, and ultrasound helps define it's usually not hard to figure out where the location of the necrosis is, but you can see how much fluid and how much solid necrosis is there. You can see what the vascular flow is and the relationship of the necrosis to the vascular structures. You can interrogate the distal bile duct with ultrasound once you get good enough. It's another advantage. I think it's important to think about the presence of portal left-sided portal hypertension. So the splenic vein often is thrombosed, and the short gastrics and the epiploics have huge varices. And so you can get into some bleeding getting through the stomach. But we make an anterior gastrotomy, use the ultrasound to localize where we're going to make our posterior gastrotomy. You can potentially get disoriented and get into the retroperitoneum, not into the necrosis. So that's, I would say, be careful trying to get through the back of the stomach. Oftentimes it bleeds, and if it bleeds, you got to open it up a little more counterintuitively. You got to open it up so you can see what's bleeding. It's easy enough surgically to stop this venous bleeding with compression and suturing. I like to put a big GIA stapler to make a cystogastrostomy, to make that hole as big as possible. I use a seam guard, and then I oversew that whole thing with a proline suture, again, because of the potential venous bleeding in the wall of the stomach. Debriding the necrosis is an art, and the trick is just take what comes out easily, because you don't want to debride the anterior wall of the portal vein. If there's a major hemorrhage, you can pack that area. You need to pack it, especially if it's a big cavity, you got to pack it with a lot of laps, and then do your Cochran maneuver so you can get your hand behind the SMV in the portal vein and give a little posterior pressure to see what you're into. But once you get the necrosis debrided, irrigate it thoroughly, and then basically close the anterior stomach in whatever way you want. I think the stomach a lot of times is really thick, and so I like to sew everything rather than stapling the gut. Do your cholecystectomy. Image the bile duct, please. Please image the bile duct in some way, shape, or form. In biliary pancreatitis, you don't want to leave a small stone. And then, again, depending on the clinical situation, you can put a feeding tube in. You can put a GJ tube in to decompress that stomach if they haven't been able to eat. If it's somebody who's like walking wounded, they've been home and eating, but they're just, have early satiety and pain and flu-like symptoms. I don't always put a GJ tube in, but I definitely am not shy about that either. And so I'd say it's easy enough to get access to the gut. It's easy enough to pull that tube out when people don't need it. So that's sort of a summary of indications are important, operative approach, do the gallbladder. And that's, we've actually published a few videos. Tom Maatman, Maatman, is the first author on a couple of videos that are out there, one in Journal of GI Surgery. I can't remember where the other one is, but there's some intraoperative tricks in those videos.
Well, that's a perfect, eloquent, technical description. Maybe just to summarize two other points and one to leverage on yours, which is that patient selection for this is critical. We can't be operating on the wrong patients. Otherwise, things certainly go sideways with this technique as well. The other thing, of course, is just really gentle, soft, cautious tissue handling, no matter whether it's from the very start of the incision or all the way into the last stitch. The educated finger and experienced finger is certainly helpful, but really soft. And Nick, I was just hoping to close out here to ask you about two other things. The first is that you have a tremendously close and large family. Your wife, I hope it's okay if I say, is also a surgeon. You guys have an amazing group of kids. You are a family guy. How do you balance all of that? How do you balance life and work and music? And before you say it, you can't start with not well, because I know that's not true.
The degree of I think balance in life is something that is so critically important. And everybody, through my life, I'll just speak to my own experience, but I have been wildly imbalanced at various points of my life. And I married up, for sure, Jennifer Zyromski, MD, surgeon, wonderful doctor, even better mother, very tolerant wife. And, she keeps me in line, man. I mean, she tells me what I need to do and when I'm not doing enough, for the family. So I think that having a partner in a relationship is really important. Jen and I, a few years ago, we decided we're going to take one day off during the week. We have 6 kids. The ages of our kids are 14 through 5. We didn't plan to have that many. They just kept coming. And you'd think 2 doctors might have figured that equation out. But in any event, and that's the most beautiful thing in the whole world for both of us. But it's also the hardest thing. Tom Howard told me this, Chad, when we were having our first baby, he said, "Congratulations. It's the best thing you'll do, and it's the hardest thing you'll do." And you know that as an awesome dad yourself. I know you are. But it's a huge sacrifice, and it's a sacrifice when you love what you do at work, and you get the rewards for doing that at work. You got to be able to put that aside, and it's been really helpful for me to have a checkpoint. Checkmate with my wife. COVID has been really interesting. We've shut down the travel. You and I were talking before we got started. We basically shut down the travel. We've been home a lot. Our OR log dropped for a while, and it was great. And I will tell you, as conscientious as I think that I am about trying to put my family first, man, I was way busier than I thought I was. I think this kind of stuff keeps up, it creeps up. And so just trying to be aware of where you are, periodically sitting down to evaluate where you are personally, with family, and professionally. Jen and I started to tell you, a number of years ago, we decided we were going to take a day off during the week in the month. And again, I mean, when I was training, this would have been heretical to say that we were going to do this. But the kids were in school. At that time, we had some young kids, but we had a nanny helping during the day. And we just take the day and hang out. A lot of times we don't do anything crazy. Maybe we go to Costco, or we go to see the financial guy periodically, or we definitely have lunch. We have a good lunch, and it's a great way to just say, okay, let's slow down and reconnect and figure out where are we and what do we need to address. And at nighttime, it's crazy and everybody's tired. On the weekends, when the kids, there's 11 different sporting events and somebody's play and something. I mean, it's just, gets to be 10 o'clock at night and you're exhausted. And so finding time in the day to talk about things and to be together when we're fresh, I think has been a very important thing that we've done to help keep balance in our life.
I'm going to immediately take that tip and hopefully when I'm a staff guy, try to incorporate that into my life. It's such a great piece of advice and great tip. I did want to dig a little further into your passion as a musician as well too. And Dr. Ball has actually played for the residents your Pancreas Blues song as part of his pancreatitis talk, and it's fantastic. And I understand that you actually recorded that with another pancreas surgeon, Claudio Bassi from Italy as well. Can you talk about how you sustain that interest as a musician and how that's been an outlet for you?
How much time do we got? I can talk about that. Yeah,
fantastic.
so this segues from the balance piece. I think another really important part of balance is to find something to do outside the hospital. We love what we do. We're surgeons. We love doing surgery. We love taking care of patients. And fundamentally, there's no more rewarding job on the whole planet than helping another human being. But it also takes a huge psychological and emotional toll. And I think that finding a way, to express yourself creatively outside of the hospital, through some artwork or whatever you do, everybody, a lot of people are athletic and they run, and I do that too. And I think that that's great. But having a creative outlet for me has been a really, really fun and important part of my life for a long, long time. And I'll tell you, that also, it's fun to walk in those circles because musicians are cool guys, and they have a totally different view on the world than surgeons do. I'll tell you that. Claudio Bassi is a hero of pancreatic surgery. He got the ISGPS together, International Study Group of Pancreatic Surgery, and wrote that seminal paper about, speaking of definitions, the definition of a pancreatic fistula. And so, Claudio is a tremendous musician, really beautiful player, really beautiful writer. And he has a lot of recorded stuff that's out there that you can listen to. So Bill Traverso was in charge of the Pancreas Club. The Pancreas Club was honoring Claudio Bassi for his lifetime contribution to pancreatology. And Bill called me up. If you have any knowledge of Bill Traverso, he is one tenacious guy. And he said, look, Claudio's a musician, you're a musician, you should play something at the dinner. And I said, no, Bill, I don't want to do that. And he said, no, you really have to do that. And I said, no, Bill, I'm not interested in doing that. And then he called me back. He said, hey, you got to play some music. And I said, no. And he said, well, at least call Claudio, And I said, fine, whatever. And so I emailed Claudio, and Claudio said, of course, Nick, we play some music, this will be great. And I said, all right, well, whatever. We'll play some music at the dinner. The dinner was in Washington, D.C. And then I thought, well, maybe I'll write a song, the Pancreas Fistula Blues, and play it for Claudio. And there it sat like that. And then it got to be like a week before the meeting, and I hadn't done anything. And so I called up Jeff Matthews. Jeff Matthews is the chair of surgery at University of Chicago. Great pancreatic surgeon, great musician also, and a really articulate songwriter. And I was like, Jeff, help. And he was like, ha, 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 good luck, buddy. And he hung up, and I was like, ah. And so anyway, so I wrote this tune on the way out to DC on the plane, and Claudio and I played it at the dinner, and it was beautiful. I mean, because we had a captive audience of like the 200 people in the world who would actually appreciate this tune. We're all in the room, and it was pretty fun. And then I thought, well, I'll bring it back and record it with the band. And a couple of years later, the Pancreas Club was in Chicago, and so Claudio called me up and said, hey, I'm coming to Indy to record the lead guitar. So we brought Claudio back, and so Claudio's playing the lead guitar on that track. And we just had a beautiful time. And I think that, again, there's so many layers to this. How beautiful is it for the international relationship and the music and things like that? But it's, for me, music is a great release, and it's a great connection with people, and it's a great creative outlet,
The last thing we'll ask you, Dr. Zyromski, is if you could go back in time and give yourself advice as a trainee, what would that advice be?
I'll tell the audience that Amir and Chad were kind enough to send some of these questions ahead of time, so this is not completely off the cuff, and I'm really glad that you did send these questions, because this is an important point. And I think that the things that we were talking about balance in life is probably one of the most important things that I missed when I was a trainee. We love what we do as surgeons. Surgical training is a major league upfront sacrifice to achieve your expertise. And there's no substitute for experience. But, the way that we did it back in the day, when it was every other night on call, and essentially giving up a decade of your life in the hospital, of good years, it was very sad to see contemporaries getting their, lake house and boats and stuff like that, starting their families. And, we're slugging it out in the trenches. And that's, there's no way around the experience piece, but, somehow trying to dial in a little more balance up front, and paying attention to your physical health, paying attention to what you eat, paying attention to outside of the hospital hobbies, and looking for mentors to help you find this balance. I have been unbelievably fortunate in my life to have so many beautiful mentors. Mike Sarr, Keith Lillimo, Henry Pitt, Tom Howard, Attila Nakib, and the list really just goes on. Jeff Matthews, who was kind to me for no good reason, beyond the fact that he's a great guy and he's interested in, in academic surgery. But those people, they don't just fall into your life a lot of times. It's okay to go looking for a mentor. Look for somebody who you admire. Look for somebody who you want to emulate. Look for somebody who's got something that you want. Hey, Chad Ball has all these incredible diverse interests. How do I be like that? And it doesn't, you don't need to, have a mentor that you meet with on a weekly basis. I happen to work in a lab where I got really close to Mike Sarr, but you can take a lot of different mentors and take little pieces from all of them. So I think you asked for one piece of advice, but it's sort of two pieces of advice, which is balance and mentorship. And I don't have a perfect equation to achieve either one of those things, but both of those things take work. It may sound funny, but it takes work to achieve balance. It takes work to develop a relationship with a mentor. And so those are the ideas.
Surgery gate, they give you a tip. Eat when you can and sleep when you can, but just don't mess with it. I'm talking about the pancreas, yes I am. It'll give you grade A, misery and the blues. Don't look at it, don't touch it, man. Not even a little tweak. Next thing you know, that damned old thing gonna start to leak, and it'll give you grade A misery when you get those grade C pancreas fistula blues. My, hey, one pancreas fistula sure can spoil your day. It'll give you grade A misery, man, from grade C fistula blues.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. We love to hear your feedback and comments, so send us an email at podcast.cjs@gmail.com or tweet at us at CanJSurge. You can check out all of Dr. Zyromski's music on his Spotify channel, and we've put the links in the show notes. Happy 2021.
Tracking our troubles has become quite the rage. Now, Brother Claudio got us singing from the same page. We singing about grade A misery, yeah we are. When you get those grade C fistula blues. One pancreas fistula can wreck your day. That juice leaking on the ceiling, and that old SMA, yeah. Grade A misery, it'll give you grade A misery from those grade C fistula blues. Dues have been paid, I'm glad to say. Professor Bossy, you sure have made the grade. I'm talking about grade A misery, yeah. From the grade C fistula blues.